I am the co-vice chair of the Global Health Member Interest Group at the CFPC. And together with Archana Gupta, who is the chair of the Global Health Member Interest Group, we are very pleased to welcome you all to the second webinar in our webinar series on the impact of COVID-19 on marginalized and structurally vulnerable populations. And today's webinar is on caring for the homeless population during the COVID-19 pandemic. And we have a great panel today who will be able to share their insights on this topic. And before we continue, I'd like to take a few moments to acknowledge that the lands on which we're hosting this meeting include the traditional territories of many nations. The CFPC recognizes that the many injustices experienced by the indigenous peoples of what we now call Canada continue to affect their health and well-being. The CFPC respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all attendees to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. In terms of other housekeeping matters, this webinar today is recorded and will be shared to everyone who has registered. It is accredited for 1 main pro credit, and therefore we have to disclose any potential conflict of interest. So none of the speakers today have any conflict of interest to disclose. In terms of financial support, this program has received financial support from the CFPC through a member interest group section project grant, and we have received in-kind staff support from the CFPC. Special thanks to Rowena Sims, who have helped immensely to organize this webinar, and we don't have any potential bias to declare. So without any further delay, I would like to introduce our amazing moderator today, Dr. Jennifer Hume, who is an emergency physician at University Health Network in Toronto, an assistant professor at the Department of Family Medicine and Community Medicine at U of T. And she is the medical co-director of the Inner City Health Associates COVID-19 isolation and recovery sites. So thank you, Jennifer.
Thank you, Catherine.
Sharing.
I thought maybe we could just start by going around the room and introducing ourselves as panelists. I'm very, very, very honored and excited about the company that we're keeping today. And it's always very nice to see Mia and Suzanne. We know each other from the COVID recovery site in Toronto. Maybe I'll start with Mia. Can you say hello?
Hello, everybody. My name is Mia Benight. I'm a person with lived experience. So I've been a peer support worker for UHN in the ED department, Toronto Western and Toronto General. And I currently hold the position of TCAT case manager at St. Stephen's Community House and the neighborhood group. Hello. Is there anything more I should say? Okay.
Hello, that was so lovely, Mia. So good to see everybody. I'm Suzanne Schuch. I'm a family doctor here in Toronto. I am a First Nations and Black by parentage and heritage. I work here at St. Mike's. I also work with the Inner City Health Associates, and I am the Indigenous Health Lead at the DFCM here at the U of T. So welcome. I've been here for working with COVID with you guys for the year, so I'm very happy to have the talk today.
Thanks, Suzanne. Marie-Ève?
Hi everyone, so happy to be here. So mon nom est Marie-Ève Goyer. I'm a general physician here in Montreal. I'm the head of Inner City Health in downtown Montreal. And I was in charge of starting our isolation unit for COVID for people who are facing homelessness. And I'm also in charge of implementing injectable agonist treatment here in our low threshold OAT clinic.
Merci, Marie-Ève. Janetta?
Yeah, hello, bonjour, Tanse, I guess, because I'm reaching you from Edmonton, Alberta. I should take a stab at pronouncing it. The name is in Cree, it's Amiskwachi Waskahigan, and Suzanne has to tell me if I said that correctly or not. But that's where I'm calling from today. I am a family physician here at Department of Family Medicine, University of Alberta. I have clinical interests all over the place. I do full spectrum family practice, special interest in addiction medicine, have a very socioeconomically disadvantaged panel. I do some obstetrics as well. And I do quite a bit of research. So I've been doing quite a bit of research around the intersection between COVID and urban underserved populations, especially the homeless.
Thank you. So we're obviously gathered here today because of our common interest. And, you know, the pandemic and our response has obviously dramatically impacted the health and well-being of people experiencing homelessness. I think we want to spend our time storytelling a little bit and telling our truths. And we really want to leave you with a sense of what you can do going forward in terms of clinical practice, in terms of advocating and influencing specific policies that might mitigate the impact of the pandemic on people experiencing homelessness. I think, like a lot of others, I was very excited initially at the beginning of the pandemic that there was a sudden interest in solving homelessness as a collective problem. There was like this sudden wide recognition, oh, the shelters don't even meet SPEAR guidelines for, you know, humanitarian emergencies. And it seemed like in the context of COVID, there was suddenly like more political will, even in being creative in terms of providing some temporary housing options for people. And there were little COVID miracles everywhere, you know, so I suddenly had the joy and the pleasure of working with Mia, you know, first at the recovery site and then in the emergency department at UHN, which was like, seemed impossible before COVID. All of the bureaucratic nightmares suddenly just dissipated, and like it was just a time of hope and happiness. Like, I'm being very honest, you know, big institutions like the one that I work in were finally interested in genuine partnerships with community-based organizations, and I thought, okay, this is a start. We can't go backwards from this. This is really positive, because once you open the floodgates, you know, we can't go backwards. I think though, as the year has progressed, you know, the cracks have really started to show, right? The COVID variants have ripped through congregate living settings in Toronto in the last 2 months. People are 5 times as likely to die of the virus. The homeless have been swabbed 10 to 20 times more than the general population. And they've been pushed into encampments because they're afraid for their own safety. And in the encampments, they're getting frostbite. In the encampments, they're getting burns. And then they're being forcibly removed from these encampments. So the isolation hotels have been a really good option for people, but there's still so much uncertainty about how long those hotels will be around for. And that means people can't plan for their future. And they still don't have agency to be able to plan for their future. And we can't plan even to support them in the future because we don't know what the future brings. So we just want to recognize, and the poison drug supply has also killed more people than any other time in the history of the opioid crisis. So we're not going to talk about these issues today, actually, but we just want to recognize that these are the big issues, right? Causing moral distress and in feeling unable to, you know, identify effective interventions. We did want to focus today on what we can do to intervene as family physicians, you know, at a micro, meso, macro level, and leave with some practical ideas. So Marie-Ève is going to start us off, maybe just talking a bit about harm reduction strategies and SOS prescribing to support people in isolation. Suzanne's going to walk us through the Indigenous definition of homelessness and what have been sort of the actionable things that have come out of that and what we can learn from that. Mia is going to talk about the role of peers and people with lived experience in supporting people during a time of really fractured social supports. And then Janetta is going to talk about some of her research around macro policies to help mitigate the impact of the pandemic on people living in homelessness. and some of the harms, obviously, of precarious employment and low levels of social assistance. So maybe I will throw the ball to Marie-Ève.
Oh my God, I would have so many things to say, but yeah, just to start with the fact that I think we should realize as doctors, but also as a society, that often we just don't look at homelessness and the reasons why. And with my hat of an addiction doctor, we have to realize, and I think that's what COVID showed us, that often addiction is behind, and addiction is creating or perpetuating homelessness. And I'm saying that not to say that it's the only cause of homelessness, and homelessness is much bigger and complicated than that. But I think as family physician, that's a place where we can certainly intervene. And then we have many tools that we can use to help these people. And what was striking in Montreal, and I guess in many other provinces, is that when we were providing isolation units for people facing homelessness, the addiction was creating a lot of discomfort. And if we were not doing anything right at that moment, people were not comfortable, they would want to quit, and that would create much more problems. And we certainly don't want to create more problems. And I'm saying that because what we realize is that with basic interventions, such as wet shelters, so having the possibility to have alcohol served, and we could frame that in a way that it's safe for people and they don't get too intoxicated, but they don't go into withdrawal. Or, for example, to prescribe methadone, or even to replace the illicit substances that people were using on the street. That would make the isolation period very comfortable and easy, and that's not costly, that's not complicated. And if not, then we would occupy or force public health order into people that would occupy beds and be thrown into withdrawal and occupy hospital beds. So I mean, either in a humanistic point of view, where you want the person to feel welcome in the isolation unit, to feel good, to be comfortable, and to have a 14 or 10 days period where they're not traumatized and they feel okay. Or on a very pragmatic way, if we don't want to create more problems and to create more withdrawals of people needing to be in the hospital, I think we really have to look at what we can do for addiction. And this is also leading the path. So we were distributing cigarettes, and we were distributing alcohol, we were prescribing methadone and opiates. And this leads to the path of what we call safer supply. So the safer supply strategy is to remove people from having to buy on the street illicit, most often contaminated substance. And this is a strategy that is going on, COVID or not, because of what you said, because of right now, most of the illicit substances are very contaminated. But, and as you were saying, a lot of what we want to implement for years, we had the opportunity to do because of COVID, and safer supply is one of these strategies. This has shown another benefit that we were not thinking about, is that if you replace and if you make people comfortable and they don't have to go on the street, or they don't have to go into withdrawal, then you offer a very secure isolation period. And I think this is something very easy for us as general physician to do and to intervene. And I will put in the chat, but if some of you are more interested, more and more provinces are writing guidelines on that. And we have written specific guidelines to how to replace and how to help these people when they are in the isolation unit. So I'll be happy to share.
Thank you, Marie-Ève. And maybe this is actually a good segue to move, if you're okay, Mia, to talk a little bit about, because this is very specific to people who are isolating, right? Who have been asked to isolate because they're under the investigation of COVID, or they've been identified as high-risk close contacts, or people with COVID in isolation. So maybe this is well timed to talk a little bit about the role of people with lived experience in supporting people in isolation, and then maybe talk a bit more broadly about your experience during this pandemic year.
Okay. I'll start by giving you a little perspective on what my lived experience is and has been. Almost 6 years ago, I had a chronic addiction to alcohol, crack cocaine, methamphetamines, and nicotine. And, you know, that took, I mean, I've been on a journey of recovery and harm reduction since. I went cold turkey with the help of my physician, and for a couple of weeks, it was really, really tough. I got through that and started to remember myself as a person, not an addict, with the relationship between my clinical therapist, my physician, and my psychotherapist. And then I was going to 12-step meetings. The path took me into the isolation hotel in June of last year, and I became a peer support worker. I was really excited because it hit me that all that lived experience and the trauma, you know, my addiction came from sexual-based trauma in my childhood, and I didn't understand any of that. The drugs and the alcohol, all of that made me feel better. And I managed to have about a 15-year experience in and out of using. But when I was using, I felt a lot better and everything seemed to make sense. But it deteriorates the body, the mind, the emotions, especially methamphetamine. The psychosis of that was very traumatic in itself. So when I stepped into the isolation hotel and I started to work with people that I could relate to, I understood what they were going through. I understood homelessness. My addiction brought me to homelessness, the inability to respond to my life circumstances and to manage my energy in a way that I was able to take care of myself. And it all just falls apart really quickly. You don't have choice. There was no choice in the matter when I was experiencing addiction. So in the isolation hotel, when I started, they just introduced the MAP program. They hadn't had an OPS site at the time, but there was all these peers, people that I understood, people that had gone through similar experience of myself. And I'm like, hello, how are you? I'm here to support you in this experience of isolation. And then I got really interested in, oh, there's the nursing team and there's the doctor's team. And I just interjected myself and said, hi, how can I be a part of this? How can I help? And that is a huge word. First it was, hi, I'm a peer. And I introduced myself as a peer to these people that were my peers. And I said, I see you. And then I introduced myself to the clinicians and all these other people. And then I realized there's a whole team, a whole spectrum of people on the same wavelength. We want to help. It was an incredible experience. So being a peer, I noticed this is the trend. There are people coming into the isolation site that have addiction issues, trauma. They don't understand what their trauma is. And the other thing is they're not clear about their mental health or mental unwellness diagnosis. There's lots of gray area. Oh, I've got this diagnosis. These are conversations I'm having with peers, people in the hotel, clients in the hotel, patients. And I started to say, I had the same experience. And what really helped me was being honest with my doctor and saying, I don't understand any of this. I would like to know why I feel this way. Why does my brain work this way? Why does my emotional body feel anxiety most of the time? And they're like, yeah, I get that. This has been my experience. And And I don't have a choice out there at being homeless. I don't know where to go, where to look, who to talk to. I don't know who to trust in this journey. So there's the peer role, right? There's that camaraderie, there's that vulnerability that allows people to engage in conversation that they wouldn't engage with people that have specialized knowledge and know a whole lot about you, but don't know anything about your past, right? But they know a whole lot about your condition. And there's, to bridge that gap, that's the peer role, is to help that gap be bridged. The peers talk to people, there's a team. And when, you know, people in active addiction, people with homelessness see that relationship, they start to trust that they're in the right place and they have the stability and support. There is a flexibility that starts to open up in their emotional body. That's what I noticed. It's so, so important to have some flexibility, because in addiction, it is dense and restraining and conflicting and confusing. The peers bridge the gap, and that conversation starts to happen. And then the clinicians are able to, you know, gather more information about what is actually going on in the mind and in the heart and in the whole part of the being, instead of just that one portion. That diagnostic clinical perspective starts to open up, and people start to get well. Even in isolation, they start to get well. And it's funny because you see the struggle happening is when the discharge date comes up and people are asked, well, you're cleared from COVID, now you got to go. And then there's a whole bunch of kickback, right? People don't want to leave because they're supported and they're heard. And there's a level of stability which helps them to remember themselves outside of addiction. And I think that's the key. That was the key for me, is I had people that helped me remember who I am, not as an addict, not even as a parent or all these other things, but who I am and what I can contribute. That's the important, you know, it's so important to remind people that they have value and they have the ability to contribute. That's huge. And in those isolation, the structure of those isolation hotels, all of that is, it's taken care of, like the role of the clinician, the role of harm reduction, the role of the peer support. There's movement, and well-being starts to be remembered. Yeah, that's, it's huge. It's huge. And then we get faced with all the other issues of where do we go from there, right? My experience in the shelter system was horrible, absolutely horrible. Yeah, I needed a shelter, but you go in and it's not the staff, it's the structures, it's the systemic structures and policies that compartmentalize people and never really address what's going on. Giving people food and a cot doesn't get them well. It actually creates a whole lot of anxiety, because then you're afraid of your stuff being stolen and the dynamics and the unwellness of people, and then it's triggering and isolating again. It's very, very challenging. So I can see why people go out into encampments, because they have the ground underneath them. There's stability in the ground underneath them. There is, you know, that the heartbeat there that you can see. I know that myself, when I slept outdoors, I felt a whole lot better in the morning than when I did when I woke up in the shelter. I know that there are, you know, I have acquaintances that are street workers, women that would prefer to be, you know, in their encampment than in a shelter, because there's a whole lot of other things going on there. They feel better, you know, and this is about helping people feel better about themselves so they can start to pull back those fragments that have happened through trauma, start putting themselves back together. And in working in the ED, I have nothing but wonderful stories. It's challenging, but it's awesome. I love working in the ED. There's a lot of you know, you get people coming in with, you know, really acute withdrawal. A lot of stuff is happening. And when the peer shows up, there's a buffer between those that are controlling the outcome of my experience here and the peer support that says, yes, I see you, I hear you, and how can I best advocate for you in present time? So those underlying health conditions can be addressed. You know, there's lots of kickback, because sometimes really the main thing about getting into the ED is I'm having really bad withdrawal right now, and there's a poisonous opiate supply out there, and I don't have the means to get what I need. And how am I going to get that? And to advocate for that, and to talk directly to the nurses and the physicians, and to bring not just the emotional part, but the whole lived experience, to kind of shift that energy into what is the best care in present time right now. And often more of that wound care, more of those underlying conditions are looked at, because the peer can adds a distraction to all the other things that are going on, allows the vulnerability, and doesn't judge. So it's been a real honor to be a peer, and then to move into case management, and to again bring that lived experience, and to be able to say, you know, I did some really crazy things when I was in my active addiction and have been in a place like this, and to be able to laugh about it, not to have that stigma attached to where people are at. You know, it helps uplift people. And there's another perspective that gives people ideas about who they are again, you know. But, you know, the wellness portion, that vulnerability, it just comes inherently with the lived experience and all the experience. Yeah.
Thank you, Mia. I think we want to come back to you. Every time Mia speaks, I cry. So like I'm scary right now. But I want to come back to that idea of agency, yes. Giving people agency, and getting to the point where people can be well. Suzanne, can you speak a bit about the experience of Indigenous people that you're seeing on a daily basis, and a little bit about the Indigenous definition of homelessness, which I confess I just read for the first time last night.
Oh, that's it. So yeah, I have to say, Mia, I could just spend the entire lunch hour just listening to you, and I almost wish that Jennifer would forget to ask us to speak. It's just incredible to listen to you. And there's so many things that you say that just trigger so many memories about the past year. I also worked in the shelter system since 2010 here in the city, you know, looking at just the way our own stereotypes and our own views and our own ideas of what homelessness is impacts the policy decisions that are made. And I know that you're asking about Indigenous people specifically, but I'm just going to quickly mention that, you know, the heterogeneity of the people experiencing homelessness is incredible. You know, oftentimes we'll think about single people who use drugs or, you know, mental illness. The beginning of the pandemic, one of the most important things that we realized immediately, especially for Indigenous people, was the importance of autonomy, the Indigenous definition of homelessness, and family cohesion, right? So the idea that if a person experiencing homelessness commits to being in an isolation shelter, they are doing it for the benefit of everybody around them. It's a public health service, right? We're thankful that they are doing this. And like Mia said, we should do everything within our power to make them feel comfortable as a thank you to them for what they're doing for those around them. They've chosen to leave what's familiar to them and come into the hotel at, you know, they don't know what's going to happen when they discharge. They don't know where the hotel is going to be. They don't know what services they're going to have, what people they're going to see, and they do that for us. And what we saw was, you know, at the very beginning, one of the things that we advocated the most for with the Inner City Health Associates, who really took charge with UHN when managing the isolation hotels, was a commitment to family cohesion. And we found that that would be the most important thing. And also a commitment that child services and child welfare wouldn't be involved without my involvement or without another Indigenous physician's involvement to kind of discuss what's going on first, because I think that we know that Indigenous people experience so much medical violence, they experience so much criminalization, they experience situations that are that are really excluding them from coming to care, let alone an isolation hotel. And making sure that you know that if you're setting up something that's to serve the Indigenous community, you have to include families. The number of families we had was incredible. Newborns, pregnant women, people with 5 children. You know, there was so many things. And you think about, yes, the way you meet the needs is so diverse, and it could be as simple as making sure your hotel room has internet so the child in grade 2 can continue their classes. Right? These are really, really important things that get overlooked because people aren't realizing the diversity of people in the hotel. You know, I worked with one of the most incredible physicians that many people probably know. He's like the legendary Tomislav Svoboda. And when we worked together, we always tried to teach our residents and our students and our medical learners, when you're seeing somebody who's experiencing homelessness, in your mind, you need to be thinking about, what is it going to take to end homelessness for this person, right? And there's actually situations that we have created where you cannot have your medical needs met unless you are homeless. That includes a managed alcohol program, that includes safe supply, that includes OPS on site, right? If you need those services, you must be homeless for the rest of your life, or you won't have your healthcare needs met in a mainstream. So looking at how do we shift that into something that's changing policy so that homelessness is not a requirement for healthcare. The culture of safety within a hotel is incredibly important. And that starts with peer workers, that starts with community workers, that starts with Indigenous representation, Black representation, people who understand medical violence, people who understand the experience of homelessness in terms when it comes to things like interacting with the police, in terms of acting with physicians. All of these things are really important. Also making sure that you have workers who understand and are dedicated to cultural safety for everyone that comes through. When we think about the Indigenous definition of homelessness, I know it's like a roundabout way to get to it. It is something that's so absolutely incredible to read. And it was written by Jesse Thistle, who also wrote From the Ashes. And it's an incredible book if you haven't read it. And he actually experienced lifelong violence, colonial violence in foster care, in homelessness, in drug addiction. And he had an entire journey that has now led him to be an incredibly successful professor. And he is a brilliant mind and wrote the Indigenous definition of homelessness in 2017. And it's on the Canadian Homeless Hub. It really looks at the idea of homelessness is not the lack of a physical structure. It's the lack of this emplacement. So there's so many ways an Indigenous person can be homeless. Even if you have a shelter over your head, your shelter might not be suitable to even consider isolation during a pandemic. You have multi-generational homes. We know in Toronto alone, 90% of Indigenous adults are living below the low income cutoff. You know that there's going to be, oh, somebody just put just up, thanks, Jen. You know that there's going to be considerations that we have to take. So for example, making referrals to the hotels from emergency departments, making sure emergency docs understand the definition of Indigenous homelessness and understand the definition or the need to specifically have ways to include groups that are not included and are not present, because it is critically important. We've seen the variant, it's just ripping through right now. And, you know, even yesterday I was so demoralized. I was just like, oh my God, everyone is variant, like this is, I don't even know what to do anymore. And then you have positive days when we have incredible vaccine days, and then you have, you know, mass tests that come back negative. But there's such an importance that we understand and appreciate that this is an incredible service. We got to do what we can to make people feel comfortable. And that includes everything that we've been talking about.
Thank you, Suzanne. Let's zoom out for a second because, no, not zoom out on you. We're zooming in on Janetta. Because I think we've touched on all of these micro and meso actions. And I think, yeah, let's look at the policy landscape and what that's looked like over the last year, and then zoom back in on some of the points that you just brought up, because they're very juicy.
Well, and I would say that the reason primary care has to be at the table is that with all of this stuff and ACT is that we're generalists and we're actually very good at zooming in and zooming out from the macro to the meso and the macro to the micro to the meso and back again. I mean, so you have to be at the table because I think you understand as primary care teams, as primary care providers, what is going on in the front line, but have a really good sense of systems thinking too, just by the very nature of our training. So I guess that's my intro. So I will take a complexity lens to this. There's so many intersections that happen. It's not just the COVID and homelessness syndemic that's going on, but it's everything else that goes on with homelessness that creates further disadvantage. And many of my colleagues have very articulately spoken to those points. We've got a group here that doesn't fit with society's expectations. So much policy, so much baseline policy, but also COVID policy has been normative, has been around the central tendencies in the general population, and it's become very retroactive afterthought type policy that's been thrown the way of people who are homeless. So we were already dealing with a fractured baseline disadvantaged state. And we've been thrown into further chaos. But out of chaos, there has to be a bit of command and control. That's what we have to see from public health during a crisis. But there's also been a whole lot of frontline innovation. There's been coalition building, and that's been very, very, very exciting. So again, overwhelming initial focus on containment of an infectious agent, right? We're always talking about it's in the name of containing the virus. It's not really about the people who are infected by the virus or who are at risk of acquisition or severe infection. Even though we know what the stats show for the homeless population, that they're at higher risk of everything, severity and acquisition and transmission. So all of these normative type policies came down from on high, things such as, okay, let's switch to virtual care if we can. Let's switch to individual visits instead of bringing a caregiver or a person you trust, or having warm handoffs. Let's get rid of transportation to and from places. Let's distance, let's stay home. Let's mask, let's so on and so forth. All of these things being out of reach for many people. Where do you find a mask? Where do you hand wash? How do you sanitize? How do you do any of these things, let alone how do you stay at home? So there's very little bandwidth, once again, to address syndemics, to address the fact that people were still using drugs and were actually at higher risk during a pandemic. The people, the fact that if you're going to be asked to shelter in place, that you may be exposed to more violence because it's no longer out in the open. Eventually, there were specific responses. They seem to be geared particularly to the absolute homeless. People started to realize, oh, what about this group who can't shelter in place? But there was little to no support for the relative homeless. And certainly in my family practice, there's a lot of people who are struggling and suffering in silence with absolutely no supports in place. And my colleagues have also spoken to that. We seem to have a good sense of, okay, if we're going to operate isolation units, what has to be in place in those spaces? But then what, right? What happens afterwards? In Edmonton, I think we've been fortunate that there's been a lot of push to improve transitional housing and actually come up with a little bit of a follow-up plan. I've seen more rehousing than I have in years past. But I mean, conversely, we've seen more evictions. And that's because there's also, we have to keep in mind, existing policies that were set up pre-COVID. And they were really set up for structural violence. We've talked about colonization and racialization and other stigmas, but they were set up to, you have to jump through all of these hoops to get your income support, to get your medication coverage, to get your ID. Now people who relied on in-person visits to get any of this stuff done can't get it done. Everyone's being told you need to phone in. Well, what if I don't have a phone? Everyone's being told to use a virtual visit or Wi-Fi or fill in this tool online. I mean, that's out of reach. I got a lot of people who can't go to the public library to use the Wi-Fi because it's closed. So what do you do with all of that? And then people are basically, the implicit assumption is that it's that person is at fault for not following through with the process and the procedures. So structural violence all around. I mean, certainly not with COVID intended, but it's there, and it was a perfect setup for failure. We've seen short-lived protections. There were beautiful silver linings early on in the pandemic, as we've seen, like specific income support, specific rent protections, and so on. They were unsustained. So now we've got deferred harms that we are now dealing with. I'm seeing more people getting evicted now than in the first wave. That buffer's gone. And I think the will to deal with it is waning because people have that fatigue around it. So I do not want to do doom and gloom, but we have to just understand that, I mean, those initial command and control top-down policies were eventually going to not meet the needs of an outlier population. Enter frontline teams, enter people like us, primary care providers, and lived experience. And so what happens is we had people from the ground up pushing policy to change. So things like encampments, things like coalitions of frontline groups came together to address those policy gaps, and I dare say have worked more closely than ever before. And there were natural connections that people just built on and recognized, you know what, I want to be here, I want to lean in, I want to help. There's a gap, I've recognized a policy gap, I'm going to respond to it. And before you think that the only policymakers are from on high, remember that you guys are all policy actors, that community members, that people who are homeless are policy actors, because we can influence policy by responding and then pushing the formal sanction. I want to mention that our largest encampment here in Edmonton was called Pekiwawin, known as Coming Home. And I thought it was just beautiful because it was this space, it was claiming space during the pandemic and insisting that these are the supports we need, and this is how we're going to support our community. And it really did push local policy. Those are my brief thoughts. I know we still want to get to some Q&A. Personally, I've witnessed structural violence and grief like never before, but I have also seen strength and love in equal measure. And the work doesn't end. I'm honored to be a part of it and to walk with, not for, and to push for better. And I think that's our role, and that's what we can do as physicians, is really advocate and push for policy change.
I was going to ask you guys for some take-home messages but I think let's open it up for Q&A, because I've already heard. Anyway, I have lots of quotes written down, like we are all policy actors. Oh, sorry. Let's open it up for Q&A for 10-15 minutes, and then we'll come back to the panelists for their concluding thoughts. Do you want to type your messages in the chat, and I'll help monitor the chat from here? Or if you want to raise your hand, I can also scroll through and find people. Everyone wants Marie-Ève's phone number and email to help them through opioid agonist therapy decisions. And I can understand that, because I have spent the last year desperately calling all of my addictions medicine colleagues for incredibly challenging decision-making. So I'll leave that.
I will put in the chat also. So I have research and clinical support team, so I'll be happy to put my contacts, but just so that you know, there is an Ontarian safer supply, a community of practice that will be nationalized very soon. So I'll put the contact in the chat.
I would probably put a plug here in for the CRISM guidelines, the COVID specific guidelines. They've put in a bunch of guidance on how to support people who use drugs during the pandemic.
They're already in the chat room.
I would also add, I know that there's a comment there about intake. Having a peer worker or, do intake is a completely, it's incredible to actually get a fulsome idea of what's going on in somebody's life. I've done patient intakes where we do the, the substance use history, or the nurse does it, and we don't get the same information whatsoever. So it really, really does help to have peer workers on your team doing a parallel intake process. And that includes for substances, for mental health, for other supports that they might need, whether they're spiritual supports or friendship supports of any kind. But that was actually invaluable for us for actually starting to understand when we're at risk for overdose situations, or when we're at risk for something extremely harmful happening in somebody's life. So without the peer workers doing that work, we would have seen probably more difficult outcomes than we have. And I'm just, it's life-changing to have that.
Amen. Dawn has asked, what's the most important lesson for medical learners from each panelist that you would like to impart if they were to shadow you? Mia, do you want to take this one?
Can you repeat that again? Is this right here? What is the most important lesson for medical learners each panelist would like to impart if they were to shadow you? Wow. Okay. I think that the most important lesson that we can learn is that we are all in this together, that we all have our piece and our part to play, from peers to, harm reduction to the physicians, that the basis of a lot of these issues come from our lack of understanding or a lack of communication about trauma, about what is going, I hope I'm getting this right, is that there needs to be more conversation around what it is to experience trauma, whatever that looks like, whether that's, violence, medical violence, or however you put that. Whatever that trauma piece looks like, is to actually really put that in the forefront of what's happening with people, what is really going on with people, and to start with that gentleness, that gentle conversation, to find the humanness in all of our contributions, and to kind of bridge that gap, that separation, because we're really not separate. We really aren't. And to come across with that, have that vulnerable conversation is so important. I think it is really important. Does that answer the question, or is there some way that I can frame that differently?
No, that's beautiful. Thank you. And maybe so ACE. When I say answer, okay, let's answer live. We're doing it. ACE had asked what are some of the highest impact policies to push for, and I think it's a fantastic question.
I guess that's coming to me. Hi, ACE. Yeah. How are you? Long time no talk. So I would say right now, housing. Everything is about housing. I think we privileged that there was the National Homeless Health Guidelines that a couple of us were on, that were released just when the pandemic hit. But I mean, number one, what we put in there was housing. Give people a housing. That's the most important thing you can do for their health. So there's a lovely paper that came out yesterday by my colleague Ryan McNeil out, Yale now, used to be in BC, but it was a qualitative study out of BC. And really looking at that intersection between housing and drug use as well, and just the toxicity of the drug supply when you no longer knew where to find your regular user, when you were relying on day by day how much money you would have to procure, where you would procure, people using more meth just to stay warm, people using more meth just to stay safe, to stay awake. You give people a home, you avoid evicting people, you will keep people safer. So I mean, I would say that if you could do anything as a physician right now, is push for longer lasting housing solutions. There's been pockets of innovation during this crisis, this COVID crisis, and I think we can really push for an ongoing bunch of enhanced supports for people who are experiencing homelessness.
Thank you. Kajani asks, as a learner, what can we do to educate ourselves to better serve people facing homelessness? This isn't always addressed in the curriculum. And how can we ensure that learners are aware of the needs and the abilities to advocate for our patients?
I would just say, again, we talked about we're not just all policy actors, but as students, you are curriculum actors and you can shape curriculum, in my humble opinion. Push your preceptors to teach you, push your program directors, your curriculum directors to say, hey, I need more content on this. This is an unmet learning objective for myself.
I agree. If I can add, yeah, I think we have to realize that taking care of marginalized population is not well introduced in most curriculum across Canada, but also a very easy thing we can start right now is really focusing on how welcoming we are as a person, as a clinic, as an hospital, as an ER, and we have so many things to do and to change, and just small steps can be taken that can be either in the relationship and how we intervene and how we interact with people, and just making sure when someone enters your clinic, there's someone to say, hi, just wait a minute, you're welcome here, we're happy that you're here, and we'll be with you shortly, wherever you are. Would you need something? I see that you're agitated. Maybe you would like to have a safe place somewhere. And would you like someone to come right now? Whatever. And this is easy. And that's the first thing that's pushed aside. We have so many of our users that will not even reach the ER because of the triage. They are told so many rough things. So you're an addict, so you're homeless, you don't know where to go. You know, with COVID, homeless are not really, and they do not even enter the hospital because of that. So I think that's something all of us can really rapidly do, and where peers can be also very helpful to make sure that people feel at ease, they feel welcome, that sometimes they're a bit of someone to help them speak their voice. So yeah, that's very easy. And I think we overlook that also in med school also. We have to be very clear that we have to build a link with people in order to better serve them and that they feel welcome, and not to always have this distance position that we're taught. We need to be close to people, and they need to feel compassion and love if they want to rebuild trust with healthcare.
We have a question. We have a hand raised by Shanaz. I see you. You can go ahead and ask your question.
Are you asking me? Sorry. I was wondering how homeless people and undocumented people who work in long-term care can access the COVID vaccine.
I think there are actually some answers from the audience of people who are Suchitra is working at a refugee center providing vaccines. So technically you do not in Ontario have to provide an OHIP number in order to be registered for COVAX. There are lots of concerns about the need to put in an actual OHIP number when you register online, but I think we've moved past that in the last week and a half to 2 weeks. Just name, date of birth, perfect. There was a requirement of having a number in that field for a while, and then people were using 1111111. You know, and advocates were like, I put in all the ones and it didn't work. So there was like a lot of back and forth about 2 weeks ago. So if it got solved, that's great. It's great news. But the formal policy from the province is that you do not need an OHIP number, and that we have been reinforcing in our communications that None of this information is relayed to the police. If there's a warrant for your arrest, they will not know that you have been vaccinated. None of that information is communicated, and you can provide a fake name. Not encouraged, but you can. Just think. A real name and date of birth is nice to be able to get them the second dose. That's all. Dale asks, what can we do to address trauma and put more of our balance of our energy, I think, you know, in trauma prevention rather than, I think we're asking the upstream versus downstream question. Does anyone want to address this?
I would suggest that it comes down to relationships, healing relationships, being with, being willing to be with and just sit with it. But this is where I would tie back to what Mia had to say. I mean, involvement of people with lived experience on your team to bridge those connections, to really see, as she eloquently put it, to really see the person. I think that is, you know, the key thing to do is to just sit and be with folks. Yes, get training and so on, you know, focus on patient goals and so on. But I think it just really the involvement of people who have walked a similar path and the willingness to spend time. And that is one of those things that isn't unfortunately granted to us in many of our systems. We seem to be seeking more and more efficiencies and forgetting that time, and we've looked at studies of this recently in Alberta, that spending more time with patients actually reduces hospital visits and so on. So it matters, and it matters greatly in trauma.
Edward asked, what can we do? I'm just scrolling up. What can we do as family physicians or as members of society to prevent homelessness? It's the same, yeah. The deferred harms. And I wonder about the panelists, what would have made a difference? What would have made a difference in the coming months as supports and eviction bans stop?
I had mentioned something there around universal basic income, avoidance of clawbacks. So, you know, people who are on long-term disability here actually systematically getting less to live on, despite costs being up right now, and being told that they don't qualify for further support. Just fewer hoops to jump through in general. We insist on a lot more, prove it to me that you're deserving with this population than we would to the non-homeless, the normies. And that really, really bothers me, that I insist on more proof. It's an invasion of dignity. So pushing for fewer hoops would be great.
Yeah, I spoke to a client yesterday who, he's sick from COVID. So I was like, let's focus on this right now. But then of course it went like, well, my phone was stolen at the shelter and I require a phone to talk to my family doctor, and I missed my ODSB tribunal, like my, I don't know the official word. And so I can't actually follow up because I have no phone and I can't do this. So can you get me ODSB in the COVID hotel, right? I was like, how is the onus on this guy to do this? And to go and prove his disability, like it's just, yeah, agree, wholehearted. We've come to the end time-wise. I wonder if, do we have 2 more minutes to go around for final thoughts for from each of us, perhaps on one sort of positive thing that you've taken away from this year that you really hope we can continue to advocate for, you know, going forward. Or sort of a lesson learned that we can continue to sort of motivate our own advocacy efforts in the coming year, especially as as hope dissipates and some of the protective policies start crumbling a little bit. Maybe I'll start with Mia.
I just wanted to say one thing about, you know, how wonderful it is to hear all of you doctors talk about agency, because it's been my, you know, experience that agency is a gift. We're going to give you agency if you do these things. And you know what? The agency is inherent in the body. We are human. We have agency. And all of our policies are set up of, you jump through this hoop, you know, you can have these things. And it is just not appropriate anymore. And that's, you know, this is the gift you're giving me, is to hear all of you talk the way you're talking, and the level of consciousness that you hold around how passionate you are about giving people back their agency, or reminding them that they have agency, they have a voice, they have value, and that you are in the game of helping people, not just staying in the business of healthcare, but in the game of actually helping people get well. That's a huge gift to me, huge. And I can take that voice to people. And the other little piece I'd like to say is that it's awesome to have a home, to give home, but that's just the first part. The other part is the support that people need to stay in the home, to put themselves back together. That is, just giving a home isn't enough, because people, if they don't have that support, they don't have when they first get into their home, and I had this issue, is that, how do I live here? How do I be here? How do I unravel myself now? You know, and it's all about the follow-up care, maybe the peer coming into the home, maybe, you know, more support, so people can create a home, not just have a home. Yeah.
Thank you.
Thank you. Thank you.
I know she's a tough act to follow. Any final thoughts? Okay, thank you everyone for coming together around this topic. We realized we could have done like a 3-day session, which would have actually been really, really rich and exciting. So maybe this will lead to something bigger, but thank you all for joining us today. It sounds like a recording and a list of resources will be shared with everyone who participated. We thank you for your time and your attention, and this is just like a wonderful community of practice. So it's really an honor and a pleasure to be amongst all of you.